This video will help you understand what an AGP report is used for, how it was developed, and how to interpret its key components. The ambulatory glucose profile, also known as AGP, is a standardized visual summary of glucose data collected through continuous glucose monitoring. It simplifies how we read and interpret patterns in glucose levels, making diabetes management more precise and personalized. The first AGP graph was created in 1987 to offer a consistent way to visualize glucose trends. In 2008, the International Diabetes Center proposed AGP as a standardized format for glucose reports. This recommendation helped unify glucose data presentation across different devices and clinical settings. In 2013, the first CGM consensus endorsed AGP as a core part of continuous glucose monitoring. Since 2020, AGP has also been included in the American Diabetes Association Standards of Care, which further confirms its value in clinical practice. Now that we understand where AGP comes from, let's take a closer look at what information it contains. The AGP report has a clear and consistent layout that is divided into three main sections. The first part presents standardized glucose metrics that summarize the key numerical indicators. The second part is the glucose profile graph that shows glucose patterns over a 24-hour period. The third part provides daily glucose views to highlight day-to-day variation. Among these, the glucose metrics section is especially important for interpreting a patient's overall glycemic status, so we will focus on it in more detail. There are 10 glucose metrics in total, and we can group them into three functional categories for easier understanding. The first group includes the number of days the CGM device is worn and the percentage of time it is active. These two values reflect the quality of the CGM data. Longer wear time and higher sensor activity mean the data is more reliable and representative. According to the latest ADA guidelines, a 14-day wear period with at least 70% of active recording is recommended. The second group includes mean glucose management indicator or GMI, and glycemic variability. These three metrics give us a general overview of glucose control. Mean glucose refers to the average glucose level over the monitoring period. GMI is a newer metric that estimates long-term glycemic control based on CGM data. It replaces the older term estimated A1C and avoids confusion with lab-measured A1C. A target GMI below 7% is often recommended for adults with diabetes. Glycemic variability is measured using the coefficient of variation, which compares the standard deviation to the mean. A higher value suggests greater glucose fluctuations and a higher risk of complications. The recommended target is 36% or lower. The third group includes time in range, time above range, and time below range. Time in range, or TIR, refers to the percentage of time glucose levels stay between 70 and 180 milligrams per deciliter. A target of at least 70% is ideal for most adults. Time above range, or TAR, measures the percentage of time glucose exceeds 180 or even 250 milligrams per deciliter. Time below range, or TBR, captures the time spent below 70 and especially below 54 milligrams per deciliter. These three metrics must be interpreted together. Relying on TIR alone is not enough to assess glucose control. TAR and TBR help identify risks of hyperglycemia and hypoglycemia, which are critical for treatment decisions. Now that we have learned how to interpret these metrics, let's explore how their targets may vary depending on different patient populations. Glucose targets should always be adapted to the needs of different individuals. For most people with type 1 or type 2 diabetes, the target range remains 70 to 180 milligrams per deciliter, and the goal for TIR is at least 70%. However, for elderly patients or those at high risk, such as individuals with cognitive decline, kidney disease, or those requiring daily care, the recommended TIR target is slightly reduced to above 50%. At the same time, the risk of hypoglycemia should be minimized, with TBR kept below 1% as suggested by the 2019 International Consensus. For pregnant women with type 1 diabetes, the target range becomes narrower, from 63 to 140 milligrams per deciliter, and the recommended TIR remains above 70%. For those with gestational diabetes or type 2 diabetes during pregnancy, more research is still needed, so current guidelines do not yet provide a specific TIR goal. To sum up, the AGP report is a powerful tool that helps clinicians and patients make sense of complex glucose data. By understanding its history, structure, and core metrics, we can better evaluate glycemic control and tailor treatment for different needs. Mastering AGP interpretation is an important step toward better diabetes care.